mic working?
Yes, ish. All right, good evening, ladies and gentlemen. My name is Lisa Dixon, and I am chair of the board of Champaign County Healthcare Consumers. And I want to welcome you to this community meeting on national health reform. First, I want to let you know that this meeting is brought to you by Champaign County Healthcare Consumers and is co-sponsored by the Prairie Center, Illinois Disciples Foundation, Wesley United Methodist Church and Wesley's Christian Social Action Ministry, Wesley Foundation, IATSE Local 482, the Stagehands Union, University of Illinois Urbana-Champaign School of Social Work, the Olympian Surgery Suites, and the University of YMCA, and the Illinois Single Payer Coalition. I want to thank all of you for coming, thank our co-sponsors who helped to make this meeting possible, and we're really glad to see the room full of people. Please feel free to get up whenever you need to get something to eat or drink, or to use the restroom. The restrooms are out the door back there on this side of the room, door and located to the right as you exit. I want to make sure that everyone got your packet of materials, your multicolored packet of materials. You should have an agenda, etc. Let's see, an agenda that lets you know what the program is for tonight. You also have other materials in your packet. So you have a salmon-colored, white-colored, lavender, goldenrod, gray, I suppose, green, and sky blue. So if you have all of those, you have your packet of materials. As you see, we do have very importantly, we do have a half-page handout at the top of your packet that explains the guidelines for the participation at tonight's meeting. We trust that you are all here with good intentions to come and learn about health reform. So, ladies and gentlemen, this is not one of those town hall meetings where people get to yell at each other or yell at anyone up here. And that's really not a good idea. So, this meeting is organized by a community organization for the purpose of presenting information. Okay, so we just wanted to make sure that that was clear to everyone before we begin. I also wanted to ask you, so that was my cue to remind me, to turn off your cell phones, or at least to silence them, please, during the presentations. Thank you. We're going to have a question and answer session toward the end of the meeting, and because we have a limited amount of time, we do ask that folks refrain from making testimonials or commentary, but to really focus on asking questions about the proposed legislation. That information is going to be presented to you. I want to take a moment to talk to you about why we've organized tonight's meeting and what you can expect. We are, ladies and gentlemen, at an historic crossroads, a crucial time in history for healthcare reform. Let's not forget that our nation, our Congress, our president are working on healthcare reform because we, the people, have made it a top national priority. We've called for health reform and our legislators have taken up the call. We should feel good about that and not lose sight of why this is happening. So, now that we've made the call, we're now witnessing the actual legislative process unfold. And it's not very pretty. So, we are inundated with politically driven, industry-driven messages, misinformation, myths, distractions, in some instances outright lies, that make this process all the more confusing. Now, you might be inclined to be disgusted or angry and to give up and sit back, but we cannot do that, ladies and gentlemen. This is really too important. That's why we've organized this meeting tonight. We want to help provide our community with important information about healthcare reform so that people can understand the legislation that's being put forward and understand how it will affect you so that you can take action to advocate for the reforms that you support. Since every special interest involved with healthcare is weighing in on the process, we need to make sure that the consumers have a voice in healthcare reform. So tonight we're going to provide you with real, true information that is not politically motivated, nor is it driven by partisan or special interests. We promise. I should make clear, however, that Champaign County Healthcare Consumers does have a clear position on healthcare reform. We believe that healthcare is a basic human right and that everyone should have access to quality, affordable healthcare, and we want real healthcare reform. Champaign County Healthcare Consumers has a unique perspective to contribute to our community's understanding of healthcare reform. Every single day, we work with consumers who are having problems with the healthcare system. We see people from all walks of life for whom the healthcare system is not working. And we understand healthcare from the ground up and from the inside out. And all those statistics that you hear being bandied about by so many folks in the media, for those at CCHC, those statistics have names and they have faces. So when we evaluate the health reform proposals, we look at them from the perspective of whether those reforms will make concrete improvements in people's lives and whether they will advance the goal of healthcare for all. Now, having said that, I'd like to turn your attention again to the agenda for tonight's meeting. You'll see that we start this meeting by providing the information on various topics. In order to understand and be able to evaluate the information that will be provided tonight about the legislation, we all need to have a common understanding about the healthcare crisis and our current healthcare system, and that's why our first few agenda items are focused on that kind of information. When we get to item number 6, we'll be discussing the actual legislation and the key components. Then we'll talk about opportunities for action and how people can get involved. And toward the end of the meeting, we will have that question and answer session that I mentioned earlier. Then when we wrap up, we invite you all to stay for a little longer to come visit the tables that are set up in the back of the room. And you can get more information and or make a decision to take action tonight to try and influence health reform legislation. So, now, I know I sort of blew through that really quickly, but I hope it was understandable and comprehensive, and we're ready to begin. First, I want to introduce to you Yadira Montoya, who is the hotline coordinator at Healthcare Consumers, and she's going to be talking to you about the nation's healthcare crisis. Yadira? Thank you.
Good evening, everyone. Can you guys hear me? I speak kind of softly, so I'll try to shout. Like Lisa said, my name is Yadira Montoya, and I'm the hotline coordinator at Champaign County Healthcare Consumers. So in order to understand health reform and whether the legislation that is being proposed is good, we have to understand what the problems are that need to be addressed. I will give a brief overview, an attempt to give you a brief overview of our nation's healthcare crisis. I am presenting these statistics to you, but to us at Healthcare Consumers, these are not just numbers. Through the hotline, we work with individuals on a daily basis that are struggling and having problems with their local healthcare system. These national statistics thus represent thousands of members in our community whose struggle we witness every day as we try to help them. Our current healthcare system is the most expensive, least efficient in the world. The U.S. healthcare system, in fact, is ranked 37th in comparison to other countries that spend significantly less on healthcare. And our healthcare cost per person is $6,000 annually, triple of what is spent in Japan and double of what is spent in France. And yet, we still have a shorter life expectancy and worse healthcare outcomes. At $6,000 per person is a lot of money, but unfortunately, this number does not represent the amount of medical care that each person in this country receives. The majority of healthcare dollars do not go to paying for medical prevention or treatment services to keep people healthy. Instead, about $3 billion healthcare dollars are consumed annually by health insurance company profits, CEO compensations, and advertising. With 47 million in the country being uninsured and the number continues to grow, the state of our healthcare system is not an individual problem, but a national crisis. So you may be asking, why don't these individuals buy health insurance? People who do not have employer-based coverage, that is through their work, have very limited options to purchase health insurance. The uninsured are primarily working people who simply cannot afford health insurance, or people who have been denied coverage because of pre-existing conditions. At Healthcare Consumers, we see hundreds of clients especially those between the ages of 50 and 64 who have lost their jobs and whose jobs have stopped providing coverage and are now uninsured and uninsurable. Surveys of the uninsured who have tried to purchase coverage individually show that a large proportion of this population cannot find a plan that meets their needs. That means that is affordable, and therefore, despite having the intention to buy health insurance, almost always never do. However, the uninsured aren't the only people who need or would benefit from healthcare reform. Across the U.S., individuals and families struggle with the rising cost of healthcare while still being able to afford other living expenses. The truth is that insurance premiums are rising higher than our income, and so employers and individuals are paying less and getting more. Simply put, many more people will become uninsured because they are being forced to spend more money out of their pocket. Through the hotline, I see how both uninsured and underinsured struggle with their daily living expenses and still get the medical care they need. We have countless of stories that show that our current for-profit private healthcare system is failing. For example, a study conducted by the Commonwealth Fund found that between 2003 and 2008, employer-sponsored family health insurance premiums rose by 33% nationally, while the median family income increased only by 11%. How can families afford the skyrocketing cost of health insurance when it is increasing at 3 times their income? In 2008, the average employer-sponsored premium was more than $13,000 a year. This price is simply out of reach for almost all working class families and most of middle class families. Given this trend, it is estimated that the average cost of a family premium will be more than $17,000 per year in 2015. The problem with health insurance affordability does not only affect individuals, but employers as well. Although most individuals have health insurance coverage through their work and therefore don't see the cost of these premiums, they still pay a portion of this cost since it affects their wages and other benefits that their employer may offer if they didn't have to pay for such high cost. The reality is that both employers and individuals are spending more of their income in healthcare and receiving inadequate medical health care and still falling into medical debt and bankruptcy due to medical cost. The financial protection of healthcare insurance for those who have it continues to deteriorate. Currently, more than 50% of the population who have debt have so because of medical issues, despite the fact that 3 out of 4 people who have filed for bankruptcy had health insurance at the time that they filed for it. As healthcare advocates, we argue that we must reform our healthcare system because of the impact on our economy, but also in our society. The human cost of keeping the status quo is too high. It is both shameful and upsetting that 400 Americans die each week because we lack access to health care. At the economic level, in 2007, it was estimated that the economy lost as much as $207 billion because of poor health care and premature death among the uninsured. This amount is by most estimates as much or even greater than the cost of insuring every American with quality, affordable health care insurance. At Healthcare Consumers, we believe that health care is a human right, and therefore we are tired of seeing people get sicker and die, tired of fighting greedy insurance companies that drop or refuse to pay services or treatments that people need, and are ready for change. So now I'm going to turn it to Al Mitty, who is going to discuss the uninsurance problem here in Champaign County from a hospital's perspective. Al is the Director of Payer Contracting at Carle Hospital. He has more than 30 years of experience and has served as the Executive Director or CEO of various health plans around the country. So let's give a round of applause for Al.
Thank you. I'm going to talk about the uninsured a little bit in general and then zero in on uninsured patients at Carle Foundation Hospital. On a national basis, low-income people are more likely to be uninsured and less likely to have employer-sponsored insurance available to them. Employees of small firms are more likely to be uninsured compared to people who work for large companies. And unfortunately, the industries that are showing the greatest job growth in our country are in those sectors that are less likely to offer health insurance, while the industries that are more likely to offer health insurance are losing jobs in our country.
Could you speak a little more into the microphone, please?
Sure.
Thank you.
Could you not hear that? Because that was the best part of my presentation. Okay, in Illinois, the numbers show that 55.6% of private sector employers offer health insurance, which means that 44.4% of private sector establishments don't offer health insurance. If we look at Carle Foundation Hospital, many of the uninsured hope that they're not going to get sick, hope that they're not going to need medical care, and certainly hope that they're not going to need hospital care, but unfortunately that doesn't occur all the time. The statistics that follow are about uninsured people who needed hospital care, had an injury or became diagnosed with an illness that was serious enough to warrant hospital services. Over the last 5 years, between fiscal year 05 and fiscal year 09, the number of uninsured cases at Carle Foundation Hospital has grown by 32%. And the charges for services provided to uninsured patients has grown from $14 million in fiscal year 05 to over $33 million in fiscal year 09. This slide shows the growth of uninsured patients as a percent of non-governmental patients. The uninsured now constitute 14.2% of our non-governmental patient load at Carle Foundation Hospital. By non-governmental, what I've done is excluded Medicare, Medicaid, workers' compensation, and TRICARE. And of course, as the number of unemployed persons has increased and the government has encouraged the expansion of Medicaid, our Medicaid population volume has grown from 18% of total patient volume in fiscal year 05 to more than 21% in fiscal year 09. Hope I don't lose this. This slide shows that while the charges incurred by uninsured patients at our hospital have grown from 14 million to over 33 million, the amount that the uninsured patients pay us remains in the 3 to 4% of charge range. So from a hospital's perspective, obviously we'd like to see more people insured, and by the way, those of you who are insured are subsidizing these costs for people who are not insured. If we look at our uninsured population, the majority of those patients are employed. Over the last 6 fiscal years, the percent of uninsured patients at Carle Foundation Hospital that are employed has remained relatively constant at about 55%. But what this slide also says in a way is that being employed doesn't directly correlate to having insurance, and having a job doesn't mean there's a guarantee that you're going to have health care coverage. If we kind of drill down on the uninsured population in our hospital, 55% again are employed, 5% of our uninsured patients are students, 0.1% are children, 2% are disabled, 1% are retired, and 37% of the uninsured patients are unemployed. And I put the unemployed in, I put that in red to highlight that between fiscal year 08 and fiscal year 09, the number of unemployed, uninsured patients increased by almost 30%. That's in 1 year. Now, who are the uninsured? Here are some employed. These are examples of employed people who are uninsured. And I don't mean to pick on any particular industry or anything like that, but if we look at this, uninsured employees of restaurants and bars had almost 3.2 million in charges and paid 0.8% of those charges. These charges doubled for that sector in 1 year, and the encounters increased 27% in 1 year. The average age of those people was 26. Government and school district employees, we think all of them are insured all the time. They incurred in it, this is a 2-year period, fiscal year 08 and fiscal year 09. They had $2 million in charges. They paid 3.6%, and their average age was 34.7. Uninsured employees of nursing homes, assisted living facilities, and other healthcare organizations had 159 encounters and 641,000 in charges. They paid 6% of those charges. The average age was 30.5. Students had students who are uninsured that come to the hospital had almost $2 million in charges and paid 3.6% of those charges. Leading local private employers, if you look at the list of leading largest Champaign County employees, private employers, had 363 cases, 1.1 million in charges, and average age of 30.1, and paid 3.6% of those charges. Some additional statistics on the uninsured. Young people, a lot of young people don't have health insurance, and a lot of young people are electing not to have health insurance. And I don't mean that as just a willy-nilly choice. They may not, for a lot of reasons, they may not have health insurance. They may not, they can't afford it. They may think they don't need it, or they may not see any value in purchasing private health insurance. But of the uninsured patients at Carle Foundation Hospital, 49% of them were less than 30 years old, and to me that's pretty darn young. The average age of an uninsured patient admitted to the hospital was 37. That's also pretty young. The average age of an uninsured patient admitted and staying more than 7 days, and that's a long length of stay, that age was 42. There were 44 uninsured patients with charges greater than $100,000, and 9 of those people were under 30 years old, and the average age of those people was 43. And there were 126 inpatient admissions for uninsured patients that stayed longer than 7 days, and our average length of stay is about 4.3. Also what we call our case mix index for the uninsured patients is higher than it is for commercially insured patients. What that means is that generally the uninsured patients who are admitted to the hospital are sicker and require more resources than the commercially insured population. Conclusions, the number of uninsured patients is rising significantly. Most of the uninsured are employed. Uninsured patients come from a wide range of employers, and all age categories are included in the uninsured, but the uninsured tend to be younger. Thank you.
Off to a good start. I haven't broken anything yet. So, as your agenda says, my name is John Ramsbottom. That's not a misprint. And we're at number 3. I should tell you a little bit more about myself. I am an academic by profession and not a specialist in healthcare insurance, or even economics, as may become apparent shortly. But I have, for the last, getting on for 3 years, been a member of the Healthcare Access Task Force, part of CCHCC, that was created really to address the local healthcare crisis, beginning with access to Medicaid services.
I'm sorry, but can you, yeah. I'm hard of hearing. I don't know if anybody else in the room is.
Well, I don't. Around me, a lot of people get hard of hearing. So, thank you. So my task tonight is based largely on my experience and concentrated study over 3 years to look at how health insurance operates, even if you have it, and secondly, to suggest ways of evaluating the various proposals for health reform that have come out and will continue to, I guess, for a while. Much of the debate that you've been hearing in the last month has been about proposed legislation that has not even been finished. It's been complicated, confusing. However, there is agreement, I think, that the current healthcare system is not working. It's very expensive, it's wasteful, and it does not guarantee access to care. And that's the key word, access. So on your purple sheets, mine's not purple, access is right up there. That's the first of several terms I'm going to be referring to on this glossary of healthcare terms. And it's at the top because it's the most important. No matter how well you think you are covered, unless you can actually get access to care, it doesn't matter. Access is the ability to obtain needed medical care. Now, there are lots of reasons why access might be difficult to get. There could be a shortage of doctors or medical facilities in your area. Fortunately, that's not the case with us. Instead, everyone who has ever walked into a waiting room or an ER knows that the real obstacle to seeing the doctor is having the right insurance. In most cases, in fact, you'll be asked for that card right up front. So, what is health insurance and why do we need it? Well, one simple answer to why we need it is because we don't have socialized medicine. That's also on your glossary number 2. If we had socialized medicine, government would employ the doctors who would be paid a set salary to provide whatever care was necessary, and government would decide how much it should cost, and the cost would be paid through taxes. But we do not have socialized medicine, and no one is proposing that we should. So in this country, health insurance is our ticket to care, and that's why we need it. How does it work? Here's my crude understanding. Insurance of any kind, I think, is a means of protecting against the financial impact of adverse events. So when something goes wrong, or even if it goes right, like a pregnancy and a delivery, we need a lot of resources to deal with it. So in terms of health care, we make a contract with a health insurer to cover our medical expenses. That's you, me, whoever. And we pay that insurer in the form of premiums. It's a private health insurance company. We also, of course, pay co-payments and amounts out of pocket up to the deductible. It's not shown here, but that's certainly part of the bill. And if it's a public insurer, and there are public-run plans, we pay, in effect, taxes. And we pay in advance. And then when we get medical services from a provider, be it doctor, hospital, lab, whatever, whether it's a checkup or a serious operation, the provider submits a bill. This bill is, by tradition, a fee-for-service bill. That's also on the glossary. And the doctor or hospital generally submits a bill for each service. And this is where our insurer is supposed to step in as the middleman and pay the bill. Now, in many cases, we know what the insurer charges us or our employer for coverage. But if the bill isn't sent directly to us, we may not ever know what the services themselves actually cost. That's just between the insurer and the provider. The price is negotiated. So, and this is a sort of sidebar, if we ever really wanted to spend less ourselves on health care, we'd have a hard time knowing how much less is still okay, because we don't really know what these services actually cost. The provider sends the bill of charges, the insurer reimburses the provider according to the price they've negotiated. Public insurers operate the same way. although Medicare has some power to limit the charges that providers submit for particular services. Okay. Now, insurance companies operate as a business. Fair enough. And businesses need to have a healthy bottom line. Insurance companies try to limit the amount they have to pay out by having as few sick customers as possible. They do this by charging more for those who have a history of illness, or possibly by excluding such people altogether. In other words, they turn them down. Now, these business principles apply whether the private company is selling insurance to individuals, to employers, or even to people already covered by government-sponsored insurance, as is the case with Medicare Advantage plans. Okay, as you're all aware, there's a wide variety of places to get insurance. How did we get our present mix of insurance in the healthcare field? I'm sure many of you, make no judgment, I'm heading there myself, God willing, many of you are already among the 45 million people enrolled in Medicare. Also on your sheet if you need it defined. Now, Ann Gargano will tell you more about Medicare in a moment. One point I can make now, however, is that Medicare is a single-payer, government-run insurance plan. At present, it covers almost exclusively those age 65 and over, regardless of prior health, and it is funded by a tax. It works pretty well. If it didn't work well, why else would we be seeing all these signs saying, "Hands off my Medicare"? What about the rest of us, the so-called non-elderly? So we're leaving aside Medicare for a moment. Group insurance, group health insurance, also on your glossary. About 60% of people who have health insurance get it through their workplace. Those who just heard, that's a decreasing percentage. Group health insurance, as we know it, took off just before and during the Second World War. First, Blue Cross was formed to sell plans to cover hospital care. That was followed by Blue Shield, which covered doctors' fees, some of them at least. And then World War II came along and there was an economic boom. Companies were looking for workers. But the government had imposed regulations to keep wages and prices under control in order to stop inflation. So instead of offering higher wages, companies offered health benefits as a way of attracting workers. In other words, group health insurance was a form of compensation from the employer, except that it was not taxed. Now, unlike in many countries, health coverage in the United States has remained tied to your job. No job, no health insurance, as so many who are now being laid off are discovering. And if your company has to save money, it might switch to a different group plan that involves the employee paying more of the cost of care through share of the premium, higher deductibles, higher co-pays, or the company might drop health benefits altogether. Then you would be out on your own to find health insurance through the individual market. That's the 60% there, more than well over half. About 14% of the non-elderly have Medicaid insurance. And of course, this is a federal program for low-income families, with each state getting some money from the federal government, coming up with some of their own, and setting criteria for eligibility. So it's not uniform across the country. Providers have no obligation to accept Medicaid insurance, and many choose to opt out because they say the reimbursements are too low. This obviously leaves a gap in access for those who are too poor to afford insurance elsewhere. A smaller group of people, about 5%, seek insurance for themselves and their families on the private insurance market. And their individuals are at a great disadvantage. Even if there were regulations that ensured that insurance companies could not turn you down, the cost of insurance for such plans would be much higher than in a group plan. And if you have an existing illness, an individual plan becomes unaffordable. Take just one example, no doubt an extreme one, but nevertheless, in the state of North Carolina, a 55-year-old with a history of illness would pay nearly $4,000 a month. Government subsidies have to be pretty high to make this plan affordable. And of course, you can see why many people my age talk about hanging on until they can get Medicare. And then there are the uninsured. Now, there's been a lot of talk about how to count these people. All right, who's in, who's out, overlapping, what's the real number? I think there are two observations to be made about this. One is the number seems to be growing. Just heard about that. It's growing largely, of course, because of the current economic recession. But are we really thinking that there will never be another economic recession, and so we don't have to fix this? Secondly, couldn't we do better? And if the percentage is 18%, that means at least 45 million uninsured. And suppose it's only 20 million, or even 10 million. Shouldn't we do a little better? Okay, turning to those who have insurance. Suppose you're fortunate enough, and I consider myself fortunate, to have insurance. Is it adequate? That is, will it guarantee access when you are sick, which is, after all, when you want it? In fact, a lot of people who feel they are adequately insured turn out to be underinsured, also a term on your glossary. Some insurance policies turn out to be useless when the insured person actually files a claim. It's only when something major comes along that people discover the gaps. Even with their insurance, they are still unable to cover the costs of illness. They have high deductibles, pay out of pocket even before the insurance kicks in. Or the policy covers only generic drugs, but the treatment for the illness requires expensive brand name drugs. To take an example, even modest co-payments can mount up when people are sick for a long time. If, for example, you are a breast cancer patient, over the course of 18 months of treatment, you might have as many as 140 doctor and other treatment visits and require up to 40 prescriptions and refills. If the copay for each of those was only $25, your expenses due to copays alone would be $4,500. Now consider that the median household income in this country is about $45,000. Some studies suggest that if you are paying as much as 10–12% of your monthly income on out-of-pocket health expenses, you are really underinsured, even if you have health insurance. The largest single cause of bankruptcy is medical debt. 65% of bankruptcies now being filed involve getting sick, whereas in 1981 that was only 8%. Of course, a family would gladly spend all of their income, as much else as they could get, to save one of their members and go into bankruptcy. But should this really be necessary? So people feel that they have good insurance until they actually need it. And if you look at who actually spends money on health care, it turns out that 97%, it's all but 3% of the total expenses on health care in a year, go on care for less than half the population. So the other half, which includes a lot of people who have health insurance, don't really know whether their insurance is any good because they haven't had to use it. And when they do have to test it out, maybe they'll find it's adequate, maybe they'll find it isn't. Insurance companies talk about selling peace of mind. But what else do we get? I mean, the insurance could turn out to be like a person who feels secure because his car has an airbag, and the airbag is made of tissue paper. Or in another analogy, also not mine, insurance is like an umbrella that melts when it rains. All right, to summarize where I've been about insurance, there are two things that insurance should do, that we need insurance to do in our country. It needs to guarantee access to the health care that we require when we require it, and it needs to protect us from the financial costs of health care. All right, now to number 4 on the agenda, where, as Ms. Dixon said to start with, CCHCC has a point of view. And that point of view is spelled out partly on the maize, goldenrod, yellow sheet you have, our principles. Now, we all recognize that the issue of health goes a long way beyond how to pay for medical care. Lifestyle choices, technological advances, the way providers organize themselves, all of these things have an important role. But the debate in Washington is focused above all on health insurance, so that is what we're addressing tonight. I should say that CCHCC does believe that health care is a basic human right, not a privilege, and that every single individual deserves access to quality and affordable care in a timely manner. The current system in the United States is not just broken, it was never designed to guarantee health care in the first place. Over 20,000 individuals die every year simply because they lack adequate health insurance. Now, CCHCC is on record as favoring a single-payer system. And you'll hear more detail from somebody much better qualified to talk about it than I later on. But in broad terms, single-payer would eliminate private insurance and its practices, like exclusions for pre-existing conditions. And these are tactics that even private insurance companies have recently suggested that they are willing to do away with in exchange for a mandate that all Americans buy insurance. But what is to ensure that the plans they offer will in fact be adequate and comprehensive? And so we get to our list of principles, much longer, but distilled here into 3, that you should sort of keep in mind as you evaluate the various ideas that come forth. Our idea is single payer. That's not being considered in Washington. Nonetheless, many reform proposals do envision a greater role for the government in regulating health insurance providers and ensuring access to care. When it comes to evaluating the legislation coming out of Congress, we will use these principles as a yardstick, and here are 3 of the most important. The first is that health insurance should provide universal coverage. Every single person should have guaranteed coverage with no one left out. Now, one way of achieving this would be to have an individual mandate. And that, of course, is one of the most recent things to appear in the Senate version. In any case, whether you are single or married, currently employed or not, currently in good health or not, you should be able to get that ticket to care health insurance. Secondly, the coverage should be comprehensive. Health insurance should be required to provide coverage for the multiple aspects of health recovery and maintenance: prescription drugs, medical supplies, preventative care, diagnostic tests, long-term care of chronic disease, as well as hospital care. And thirdly, health insurance should be affordable. This rising spiral of higher premiums, higher deductibles, low ceilings on lifetime benefits, that really needs to be broken. Health insurance should protect people from financial ruin, not cause it. Finally, healthcare costs overall are increasing at a far faster rate than the cost of living generally. Well, perhaps that is as it should be. Health is almost invaluable, at least when you don't have it. But there are a couple of problems. The first is millions of people do not have insurance at all. And second, millions who do have insurance are at risk of bankruptcy. To take action against these problems, we urge you to evaluate the legislation that comes forth alongside these principles. Now, this whole list of principles may look pretty daunting. How could we possibly fulfill all of them? Yet, take heart. They have already been applied successfully at least once a long, long time ago in 1965, when Congress passed a remedy to the health crisis afflicting an entire group of Americans, namely the elderly. Passed Medicare specifically to meet the needs of the elderly population. So now to discuss how Medicare might offer a pattern for broader and more effective health reform now and in the future, I'll turn it over to Ken Gargano.
Thanks, John. So as he said, I'm Ann Gargano. I am the lead organizer of Healthcare Consumers Medicare Task Force. And my little bit's going to be a little bit shorter. John's a professor. He's really good at teaching us stuff, but I'm just going to give a little commentary pretty briefly. But, you know, I wanted to tell you a little bit about our task force and a little bit about how we see Medicare relating to healthcare reform. So our Medicare task force is made up of local Medicare beneficiaries who are working to add a consumer voice and support legislative reform of Medicare's prescription drug program, Part D. And our Medicare task force was watching the health reform debate pretty closely, hoping that we might be able to use this opportunity to gain improvements for the Medicare Part D program. And at that time, we didn't really anticipate that Medicare beneficiaries were going to become such a central part of the health reform debate. Unfortunately, Medicare has been the subject of many of the myths and scare tactics that have been promoted publicly over the summer. So we just wanted to take a little time tonight to set the record straight about some of those things. Medicare is actually one part of our nation's fragmented healthcare system that works well, so it's important that everyone has a basic understanding of Medicare when we talk about health reform. John touched on a few of these things, but Medicare was created in 1965, and it is sometimes confused with Medicaid, which is a state-run program for low-income individuals. But Medicare is the federal government insurance program that's available to anyone over the age of 65, regardless of their income, health status, or where they live. It's also available for individuals below the age of 65 who have a disability. And as John mentioned, there's about 45 million Americans that receive Medicare benefits today. Medicare has lifted millions of our nation's elderly and disabled people out of poverty. Before Medicare was created, private insurance companies refused to cover the elderly and disabled, leaving them to fend for themselves when it came to their health care costs. With the creation of Medicare, poverty among the elderly actually was reduced by nearly 2/3. Medicare provides universal coverage that is affordable, simple to understand, easy to use, and widely accepted by healthcare providers. Medicare beneficiaries simply present their red, white, and blue card anywhere in the United States to receive the services that they need. Medicare is cost efficient and spends taxpayers' money responsibly. Medicare has very low administrative costs of about 2 to 3%, whereas private health insurers' administrative costs are at least 3 times that high. Medicare is affordable because it creates a large pool of beneficiaries, which spreads the risks and costs of the program among millions of people, something private insurance companies cannot do. I personally work with Medicare beneficiaries every day, and not once have I seen a Medicare beneficiary failed by Medicare the way that individuals are constantly failed by their private insurance. Not once have I seen Medicare deny coverage for pre-existing conditions or because the beneficiary received services that were out of network. Not once have I seen Medicare leave the beneficiary holding the bag for more than their fair share of the costs. Medicare spells out what they will cover and they follow through. Medicare doesn't need to make a profit for shareholders, so it does not drop its beneficiaries when they get sick to avoid paying out. Medicare works for millions of Americans and has broad support among the people that it helps every day. When Medicare was created, many opponents declared it as socialized medicine, just as opponents are saying about other attempts for health reform now. I want to make one thing clear. Medicare is single-payer, government-administered health insurance that pays for the cost of services provided by private physicians and hospitals. So it really does not make sense when folks say, government, get your hands off my Medicare, because it is government health insurance. Opponents of health reform have also said that the proposed legislation will cause Medicare beneficiaries to lose their coverage. This is simply not true. In fact, seniors have a lot to gain from health reform because there are amendments included in the legislation that would work to close Part D's costly donut hole coverage gap and lower drug costs for seniors. The legislation would also cut the huge overpayments to private Medicare Advantage plans. These Advantage plans have been siphoning billions of dollars out of Medicare for years without providing the services and cost savings that they promised, And our Medicare task force has been advocating for these overpayments to be cut for several years now. When Congress first began talking about creating a public insurance option, we at healthcare consumers really thought that that public option would be Medicare for everyone. The American people could buy into an established program that is widely accepted by doctors and that has a proven track record of success. Medicare would also benefit with an expanded pool of younger and healthier beneficiaries. We're very disappointed that Congress has not done this from the start. But at the end of this meeting, we will offer ways for folks to take action tonight. So I urge you to visit the tables in the back and sign on letters and call your congressmen and women and ask them to work to offer Medicare as the public option for everyone. And I also urge you to check out the information about our Medicare task force and our campaign to fix Part D. So I hope that this short background will help us all to understand the legislation that's being proposed and how it affects Medicare beneficiaries. We've taken some time during this meeting to talk about what is not working with our current healthcare system and where reform is needed, and that is very important to talk about. But it's also important for us to look at what is currently working in the healthcare system and expand on those successes. Medicare is definitely one of those successes that we need to build on. So now I'm going to turn things over to Nick Gaynor, who is a member of our Healthcare Access Task Force, to give us some insight on how the legislative process works and what we can expect over the next few months to kind of give us some background before we jump into the legislation.
All right, hello. Like Ann said, my name is Nick Gaynor, and I am currently a member of the Healthcare Access Task Force at Healthcare Consumers. I actually just finished a 9-month internship where I basically spent every single day of my life for that 9 months trying to understand the legislative process. So if anybody is slightly confused about how legislation works, how it comes out of Congress, how it's formed, I understand, because you don't have that much time in your day to try to understand it. So we'll see if we can clear things up for you today. So there is a gray handout in your packet that looks like this that tries to break it down into 6 easy steps, if that's possible. So without trying to get too much into Civics 101 here, I'll see if I can explain it somewhat. So basically there are proposals that are generated in the various committees that are in the House and the Senate. And those proposals can be done by an individual, they can be done by the staff of some of the people on those committees, they can be done by the legislators themselves. And they are proposed to the committee, it'll be debated. There's usually a markup process. You may have heard about the legislation being marked up. That's where there's amendments added, there's debates to change the legislation. But essentially, if it's good enough to get a majority vote in the committee, it'll get voted out and will be considered by the legislation, or be considered by the full House or the full Senate. That's already happened with the House and Senate committees. There were 5 committees that were in charge of, that were basically put in charge of drafting some type of health reform legislation. 3 in the House and there were 2 in the Senate. 4 of those 5 committees have already passed legislation out of their committee. They've been amended, they've been marked up. Some of them have some really, we'll talk about the kind of good and bad of the legislation. But basically, there's one committee left, that's the Senate, Senate Finance Committee, that still needs to, debate the legislation and mark it up and amend it, and then it'll be, the idea is that it'll be passed out and sent on to the Senate. So then the House and the Senate get to debate it more. There's more amendments added. There's more, discussion about, what needs to change to it, if it'll pass or not. And eventually, it'll pass the House and Senate, and then it'll have to be reconciled. So that's when the 2 pieces of legislation come together. Any differences are discussed, and there's usually some type of joint committee that can do that, that can decide on those differences, and eventually it'll go back to the House and Senate again to get approved, and then sent to the President. So after that long, drawn-out process, the President can still veto it, send it back to Congress, and start all over again. So that's what can happen. So what has happened is, like I said, the H.R. 3200 has passed all 3 House committees. It is going to be considered in the next couple weeks and months by the full House. It will be debated. There's probably going to be tons of amendments that will be proposed. It could look totally different than it does right now by the time it's all said and done. The Senate Help Committee, which is Senator Ted Kennedy's committee, has already passed their legislation. The Senate Finance Committee will still be considered in the next couple weeks, and then eventually the Senate will get to debate their legislation, and it'll go from there. The reason why we wanted to kind of lay this out before we start talking about the keys of the legislation is because you should know that it's far from decided. There are still plenty of details, plenty of things that can change, that can be added and taken away. Hopefully by the end of the night tonight, you'll get to decide. You'll have better, more clear information about the good and the bad of what has come out so far, and know, what to look out for, and know what to support and what to not support. So there's still plenty that can happen. There's still plenty that's going to be done. There is sort of this deadline that they want to, have it done by the end of the year. Who knows if that's going to happen? They've sort of been able to stay on task so far, but there's still a lot that the people need to watch out for, and the people of this country need to, advocate for or against. There's still plenty of things that you can do as the consumers to take action around this legislation. It is definitely far from over. So to understand the legislation a little bit more, we have two experts who are going to speak to you tonight about single-payer legislation, which is both in the House and the Senate in Washington. There's also single-payer legislation here in Illinois and in other states. And then we'll also have somebody else to explain the bigger health reform legislation that is getting all the attention. So I'd like to introduce Dr. Ann Sheets. She is the co-chair of the Illinois Single Payer Coalition and a member of Physicians for a National Health Program.
This is one of the advantages of being short. I'm kind of close to the microphone, and the tall people have a hard time. So it's good for us to get to get the advantage once in a while. Okay, I'm going to try to tell you briefly what a single-payer program would like. That's one of the terms we use. A single-payer program is Medicare for everybody. That means every single person in the country, from birth to death, would have Medicare. It would be an improved version of Medicare. And we need an improved version because the Medicare program we have now, as good as it is, does not cover everything, and it does not pay 100%. So a Medicare program that would cover everything would include mental health at 100%, as now it's about 50%. It would include dental care, vision care. Medicines would be under the same program, not in a Part D. There wouldn't be Part A, B, C, D. There would be one part, Medicare. Prescription drugs would be paid for out of that same program. They would be paid 100%. Medical equipment, hospice, hospital care, doctor care, your nurse practitioner, if you have a nurse practitioner for your primary caregiver, hospital care, medical equipment, rehabilitation, all of that would be paid for out of this one program. It would pay 100%, not the 80% that it pays now. It would be financed entirely by taxes. You would pay a tax into this National Health Fund. That's all that you would pay. You would not have to buy supplemental insurance. You would not have to pay any premiums. You would not pay any co-pays. You would not pay any deductibles. Medicare for everybody from birth to death. You would have complete choice of all providers. You could go to any doctor you want, any hospital you want, because everybody's in the same program. Doctors and hospitals would not be forced to join this program, but we know under Medicare, it's very rare. Up until recently, it was very rare for any doctor to refuse to accept Medicare. That only changed when the insurance companies got their fingers into it and created Medicare Advantage plans and HMOs, all of those things that made Medicare so much more difficult to navigate. But in the past, it was unheard of for any doctor to refuse Medicare. Doctors were happy to get Medicare. So we believe that almost all doctors would join this, and certainly all hospitals were. You could go anywhere you wanted. Single payer, Medicare for everybody, is the only health insurance reform that can meet the criteria that the consumers have listed for healthcare reform. It's the only one. It's universal because everybody is in it automatically. If you live in this country, you're in it. It is affordable, and it's the only way to have affordable health care. You cannot have affordable health care and have for-profit insurance companies. Those two things cannot coexist. They do not coexist anywhere in the world, including here. We have a failure of this. Other countries that have universal access to health care, not one of them has private for-profit insurance companies. They may have a tiny portion of that, but that's not what their system is based on. Everybody has to have coverage under a not-for-profit system. And a not-for-profit insurance system, by far the least expensive, is a single-payer program because you don't have to divide people up into different groups. A single-payer system makes healthcare affordable by having a budget that we have to stick to, and that budget is adequate because we get rid of this huge bureaucracy of the private insurance companies. That saves half of all administrative costs. That half of all administrative costs, when you put it into medical care, is enough to cover everybody. Practitioners, like physicians like me, get paid a negotiated fee. And I do not believe that physicians are incapable of negotiating a fair reimbursement rate with the national plan. That's just not true. Hospitals get a budget every month. They get a lump sum payment, or every 3 months. They get a lump sum payment. They do not have to go in there and every time they put a Band-Aid on somebody or start an IV line, they don't have to have a little sticker that goes to the accounting department to be put on a certain patient's bill, which is bound to be ripe with error. There's no way you can do that kind of complicated thing from the bedside to the accounting office and not have those terrible errors that you get and you say, I never got that in the hospital. They're charging me $200 for a pill that I never saw. You don't have that. The hospital gets its money to put into taking care of its patients, not into running an accounting department, and certainly not into having a whole room full of people whose job is to try to collect from all of the insurance companies. That's what a system would be like. I myself, I am a geriatrician. I take care of people who are homebound, almost all elderly. They can't get out to get medical care. I only accept traditional Medicare. That's because it's a reliable payer. My husband is my business manager, bless him. He does a beautiful job. He sends a clean claim to Medicare. That means a claim that has everything, all the boxes filled in correctly. We get paid in 2 weeks. I do not have to call anybody and ask permission to give care to a patient. If I order a wheelchair, it needs a diagnosis that makes sense. I can't order a wheelchair for hypertension. If I put down a diagnosis that makes sense, a wheelchair for fractured hip, if the person is not able to walk yet, my signature and indication of why the wheelchair is necessary, the person will get the wheelchair. I don't have to call anybody and beg for that. I know what Medicare will cover. Now, granted, there are a few things I would like to have it cover better, but it covers an awful lot. It is a very generous benefit. I don't have to call anybody up to ask whether something's going to be paid for or not. That's a huge benefit to me. I can put my time and trouble into taking care of my patients. I don't accept Medicare Advantage plans. That's where Medicare starts to fail. Under a Medicare Advantage plan, I don't know what's going to be covered, and I don't have any idea what the patient's copay is going to be. What the Medicare Advantage plans do to get customers is offer things like dental cleaning, vision care, but then if you get sick, your co-payments for chemotherapy, for hospital stays, for nursing home days, those go up. So of course they attract healthy people. When those people get sick, they drop out of the Medicare Advantage plans and go back into regular Medicare. This is the proof right in front of us of why we can only have genuine healthcare reform if we get rid of the private insurance industries. Because if we keep them, they are past masters at gaming the system. They're going to game the whole system just like they've been gaming Medicare. We need to get rid of them. So we say, one nation, one health plan, everybody in, nobody out. And by the way, we know, I think we in the single payer movement are the only realists. We know that this is going to be a real hard struggle. We also know that it's a struggle worth doing, that this is the human rights movement of our time. Just as other people gained human rights for us in the past, the right to vote, the right to be free of slavery, the right to adequate jobs, the right to an 8-hour day. Of course, some of those have been lost partly along the way. But we know how difficult this is, and we know that that is worth doing. That is where we take our stand. And we know that ultimately a single-payer program is inevitable because it's the only thing that will work. The only question is, how much suffering will there be before we get to that? So this is what we work for. Everybody in, nobody out. one nation, one health plan. Thank you. Thank you all for inviting me here and giving me the chance to talk about something that's really worthwhile. Now I turn it over to Claudia Lenhoff, who gets the job of describing the less desirable.
Good evening, everybody. Yes, I actually have a rather daunting and unpleasant task now. And when I was listening to Dr. Sheets speak and hearing about single payer and thinking about it, I really sort of felt my blood pressure going down and just, started having those visions of good things. And now that's all ruined because I need to talk to you about the dominant health reform legislation and try to make it understandable. And I guess one thing I wanted to say real quick is, and Nick will tell you about it later, but there is activity around single payer. I think it is going to be a long struggle, but I think any chance to support single payer, when people, if people feel that way, they should take that opportunity. One of the things that should be happening is that the House is going to be having a floor vote on H.R. 676. That's the Conyers single payer bill. A lot of people feel that that's not going to go anywhere, but it's still important. It's still important to talk about single payer because, as you will hear when I talk about the dominant, health reform legislation, and you think about it compared to single payer, you'll see how important it is to keep talking about single payer and keep pushing for that. Another glimmer of hope is that also in H.R. 3200, which is the main health reform legislation out of the House that's being talked about a lot, there is actually a Kucinich amendment, and that amendment would, if it sticks and passes, would allow states to create their own single payer system. Now that's not for the whole nation, but for states, and that is also something worth fighting for. Okay, so, and we do have action materials around that. Now what I am going to do, and I am really not an expert at this, but I, like Nick, spent his 9 months on the legislative process and health reform and so on. I've spent the past weeks and months really trying to understand this stuff. I'm going to direct your attention to the green handout that you have. And what we've done here, I need to do a disclaimer and let you know that this is not comprehensive by any means. But what we've done is we've looked at some of the key components of the health reform legislation and sort of pulled those out to look at them. And on this handout, we list what some of those key components are. We have a few comments that we've offered. We have a lot more to say about this because, we're trying to be concise. We have a few comments to offer. And then in the 2 columns to the right, you can see a summary of how the House legislation and the Senate bill from the Health Committee addresses those components. There's a lot of similarity, and there are a few differences. But we think that a lot of these issues are going to be coming up for discussion. They're going to be the subject of amendments and debates, and there will be opportunities for people to weigh in on those. And that's why we're presenting this to you. Okay, let me give you a big overview of what this health reform legislation is trying to do. First of all, let me ask, how many of you saw or heard President Obama speak last night? Okay, so you will probably be familiar with a lot of what I'm going to talk about. But the bottom line for this health reform legislation is the president said this is about taking what works in our healthcare system and building on it, and taking what doesn't and fixing it. Okay, there's some things that are just rotten and you can't really fix them. But you know, so there's a lot of tinkering around the edges. But basically, what the overall scheme looks like is that people who have Medicare are going to keep Medicare. People who have Medicaid will keep Medicaid. And our nation's reliance on an employer-based health insurance system is going to remain intact. Okay? Then what the legislators are looking at doing is getting coverage for all those people now who are without coverage. They are without coverage because their employer doesn't offer it, or they can't afford it, or they have been denied coverage because they have pre-existing conditions and the insurance companies don't want to deal with them. So a lot of what you're hearing about has to do sort of with that big chunk of it, of how do you cover the uninsured or the soon to be uninsured or the fixing to be uninsured, because a lot of people really are fixing to be uninsured. The premium rates are going up, and you know, and it's getting unaffordable. Now, a main component of how to do that is this exchange that you've been hearing about. The exchange, conceptually, it's called the exchange in the House bill. In the Senate, it's called the, what is it called? The gateway. Whatever. I don't know who comes up with these names. An exchange, it sounds like, oh, you know, I'll switch this one for that one. I don't know. But those are the names that they're using. The exchange or the gateway. Basically, if you are uninsured, you would now have access to health insurance through the exchange. There would be private plans that are offering to insure you, and there would be regulations, some regulations on those plans as far as the types of benefits that they would need to offer, and also regulations on them that they can't do some of the sort of heinous things that they've been doing, like discriminating based on gender, discriminating based on pre-existing condition, you know, dropping people when, you know, when they most need the coverage and so on. So there would be some regulations in there. But basically the uninsured folks, and in some cases small employers, would be able to go to this exchange and sort of shop around and find the health insurance there. So that's the general scheme of how this is going to work. This is the overview of it. Now I want to get into some of the components. Does that make sense? Have I said anything horribly wrong? Okay. I have an expert up here, so I'm looking to him. That's a simplified version, but that's the gist of the structure. So the important thing for you to remember is it's building on what we currently have. And I'm just going to make a comment right now because I have to. I feel morally compelled to do this. You know, one of the concerns, and one of the things that we've always said at Healthcare Consumers is we don't want our nation's people to just get more of the same crappy coverage that's been hurting the people who we work with every single day. We work with people every single day who are uninsured, for sure, but also people who are insured and are getting dropped or are not getting the services that they need covered and are spending all their time and their health and their energy trying to navigate this morass of insurance bureaucracy. And we are pretty effective at helping people, but I will tell you, it takes hours and hours and hours. The staff who you have seen up here, Yadira and Ann, they spend a lot of time doing this every single day. That is not how insurance is supposed to work. That is that umbrella that when it rains, it melts. And there is a righteous anger that the American people have towards private health insurance because people have played by the rules, employers have played by the rules, they've been providing health insurance, people have been paying for it, and all that money, and then when you need it, the coverage isn't there. Now I know that's not true for everybody, but it shouldn't be the case for not one single person, okay? So, okay, I just had to get that off my chest. So we're going to build on this system. And, you know, another thing to remember, I have one more thing that I need to get off my chest, too. The other thing that people need to remember is that private health insurance, private for-profit health insurance, has an inherent conflict of interest. It is for-profit. How do health insurance companies make a profit? They make a profit by taking money in from you in the form of premiums or from your employer, and then they also make a profit by not expending money on your coverage. So that means that you have all these cost-sharing obligations, you have deductibles, you have co-pays, you have co-insurance, you know, whatever. You're always spending, you know, money. And sometimes when you can't afford it, you get in trouble with your healthcare provider and you have medical debt. And in our community, sometimes that means that you get put on a no-service list and you can't go see your doctor until you pay a lump sum, you know, amount. Meanwhile, the health insurance company has been getting your premiums and isn't paying out. That's how they make a profit. They have an inherent conflict of interest. We think they're there to cover us, but they are really working to generate profits for the shareholders. So that's something, so we're going to build on that system now, and I'm going to tell you about that. Not entirely, but really a lot. Okay, so some of the key components that we're paying attention to, and again, this is a simplified version, but there is a Medicaid expansion. Both the House and the Senate bill do propose to expand Medicaid eligibility to include more people than are currently eligible for Medicaid. In the House bill, it's up to 133% of the federal poverty guidelines, and in the Senate bill, it's up to 150%. Another aspect of the House bill is that they want to increase Medicaid payment rates for primary care providers to make an incentive for primary care providers to take Medicaid insurance. And in this community, we've seen a problem with providers accepting Medicaid insurance. So that's one component to look at. Another component is this exchange for individuals to purchase affordable health insurance. And in the House bill, they're calling it an exchange, and they are going to include a public option. As of now, this is all up for grabs, right? Because you heard the lesson from Nick, everything's up for grabs. But they propose that one of the options that you should have, so locally, let's just say maybe locally Health Alliance wants to participate in the exchange, maybe Personal Care does, maybe Blue Cross Blue Shield, Cigna, I don't know. And then in addition, the House bill would like for you to be able to choose from a government health insurance, a Medicare-like government health insurance. Why not just make it Medicare? But anyway, in the Senate bill, in the Senate bill there is no public option. Okay. But basically, in this exchange, which is where a lot of the people who are currently uninsured or about to be uninsured are really struggling, and also small employers in some cases, that's where you would go to shop for your health insurance products, and there would be some regulation. Health insurance products would have to meet certain criteria as far as the types of benefits that they're going to offer. Not comprehensive by any means, and in fact there's going to be 3 tiers of products. There's going to be your basic, you know, like maybe, I don't know what that means, maybe you don't care, you know, about your mouth, and so you're going to forego the dental, or they don't care about your mouth, so they're going to just offer a plan that doesn't cover dental. I don't know if dental is even included in here, but there's going to be a basic, an intermediate, and then a higher level. I just realized my hand motions are in the exact opposite of where they need to be. I apologize. I'm all topsy-turvy from reading all this stuff. There's going to be a basic plan, an intermediate, and then a higher level, depending on what you can afford and what you're interested in. Okay. On the other side of your page, there's some more of these components. I already mentioned this one, but the public health insurance option. And the public health insurance option, again, would be a government-provided form of health insurance. Not Medicaid, not Medicare, you know, something new, I guess. And it would just be one of the options. And as you've seen through the summer, it's been a huge topic of controversy, but for those of you who watched the president speak last night, you see that currently the vision for it is actually pretty small, but it's a huge controversy. Why? Well, I would submit to you that the biggest controversies and much of the noise making have been around government-sponsored health insurance, whether it's Medicare or whether it's this public option. Why? Well, those are the greatest threats to the private health insurance companies. That's where they see themselves losing out on this windfall of all these new people who have to come and get health insurance. Okay, and I think that that's what's generated that controversy. And we know that at Healthcare Consumers, because under Part D, Medicare Part D, those of you who have Medicare know what I'm talking about. Under Part D, one of the options, Congress says that it's about choice and all that, people were denied the one choice they wanted. The one choice was to go to the pharmacy with their red, white, and blue Medicare card and use that to get their prescription drugs. And the insurance industry has fought against that tooth and nail, because why? Then they wouldn't get new customers for their product. Okay, that's a little bit of editorializing. Now, the next key component to look at, and this one is really important. It's really important. It's about regulation of health insurance and consumer protections. And these are some of the things that President Obama was speaking about last night, and some of the things, there's actually a lot of agreement on this now, and the insurance companies have actually come forward agreeing that they're going to stop doing these bad things. They could have stopped on their own. They could have been ethical on their own, but now, because they're going to get this huge number of new people who are going to have to get health insurance, they've made a concession. So the concession is that they will stop discriminating based on age, gender, or based on gender in particular, based on pre-existing conditions. And then there's some other regulations. They're going to be prohibited from having annual or lifetime caps on how much they will pay out, which is a good thing, because if you remember from John's presentation, we don't ever know what the costs of healthcare are going to be. That's another thing to remember. In our name, Champaign County Healthcare Consumers, we don't mean the word consumers in the capitalist sense of the word. We mean it in terms of people using the services. But when you think of consumers shopping for something, you usually know what the price tag is, and you make reasoned decisions about whether you can afford it or not. We never can do that with healthcare, and we don't know when we're going to get cancer, and we don't know when we're going to have an accident, and and all that. So anyway, so there are going to be some important regulations. We support any of these regulations because the absence of them hurts people. We see the people who are hurt by this every single day. It's just a shame that it has taken national health reform to do this. Congress could have regulated health insurance a long time ago. But okay, so that'll make some improvements. Now, another component is that there will be an individual mandate and penalties. Okay? Both the House and the Senate bill have mandates, and what that means is that you will have to get health insurance. You will be required to do that. We have a problem with mandates. First of all, well, going back to what Dr. Sheets said, it has to be a mandate because everybody's not automatically in. You're going to have to get in, you're going to have to pay in, you're going to have to get health insurance. And there's a reason that people haven't had health insurance. It's been priced out of their reach. So there will be some mandates, and then there will be some exceptions for hardship cases for lower income folks. But that's one of the concessions I think that the insurance industry got, for negotiating, on this health reform is, you got to give us as many people as possible. Well, how do you do that? We make a mandate, and it does make sense to have everybody covered. It's just ethically, this is a little bit thorny. There also will be an employer mandate and penalties. So in both of the versions of the bill, employers are going to be required to provide some health insurance. And there are some hardship exemptions, primarily for small employers. So Champaign County Healthcare Consumers, perhaps, I think, we're the right size, will probably be exempt from having to do that if we can't afford to do that. We may be able, under some of these bills, we may be able, as an organization, as an employer, to go to the exchange and purchase group health insurance that way. Or, but we need a break, actually. Our health insurance rates are just ridiculous. We understand absolutely the plight of small businesses and small employers. But there will be employer mandate and penalties to try to get everybody to participate. There will be subsidies to individuals. There will be subsidies in the form of tax rebates, but then also subsidies to help pay for the cost of the premiums. And now I need to make a comment again. Why do we need subsidies? We need subsidies because we know it's going to be expensive. These products are going to be expensive. That's already the case. That's why people don't have health insurance. But rather than getting insurance companies to lower the costs and make it affordable to people, instead, the insurance companies are sort of left untouched over here, and they're going to make their premiums and their amounts. But meanwhile, we the people in the government are going to figure out a way to sort of trade money to make it possible for us to buy that insurance. That's a commentary. But that's what subsidies are, to make it affordable for people. And there is a sliding scale in the House bill and so on. The affordability issue, I have to tell you, we've started to look at it, and I'm not really entirely impressed with the affordability and how Congress is defining affordability right now. A lot of the definition of affordability is based on the cost of premiums, and when I look at the numbers and I think of people who I work with and my own self, it still seems pretty daunting. And there are going to be caps on out-of-pocket expenses, especially insurance gotten through the exchange and so on. But some of those caps are still pretty, there's a lot of people who end up in bankruptcy or end up in medical debt or end up being turned away from care at our local clinics because they owe $2,000. And I know to some Congress people that maybe $2,000 doesn't really seem like a lot, but it is really a lot for a lot of people. It really, and that's one of the disconnects that we have, and that's one of the issues with the Massachusetts plan also, is that they're having affordability issues. The legislature defined affordability in a certain way based on premiums and so on, but it was a little bit unrealistic for how people actually live. And when you think about this community where we live here, because of the wonderful university and all of that, the rental prices are really skewed in this community. The government says that you should not be paying more than 1/3 of your income for your housing. And then they use that to then figure out your living expenses and all that, and then what you should be able to afford. Well, that's just not reality. So that's another big issue to look at, is the actual affordability to individuals and to families. There will be subsidies to employers. On the Senate side, it'll be based on size and wages of the employees hired. On the House side, the same thing, although on the House side, you cannot get credit for more than 3 years in a row. Now, what's that about? I'm just thinking about healthcare consumers. Our situation probably really isn't going to change over 3 years. It's not like we're all of a sudden going to get a bunch more employees, paid a lot more wages and so on. We're a small organization that's probably going to stay pretty small. In fact, one of the reasons we're kind of small is because of the cost of health insurance right now. But and then under Medicare. So that's been the source of all this talk, and Ann did a beautiful job of addressing it. What's the big changes under Medicare to look at? Really, the biggest change is actually one that we support. There's going to be cuts to the overpayments to Medicare Advantage plans. We absolutely support that. It's about time, and in fact, there's been legislation in the past that we have supported that was targeted at doing just that, but it couldn't get traction and couldn't get anywhere. And somehow some of the folks in Congress remembered, oh, we wanted to accomplish that. Now, of course, it's getting rolled in as a way to get some money to help pay for the rest of the health reform legislation. But we absolutely support the cuts to the overpayments for Medicare Advantage plans. It's not going to result in a cut to Medicare benefits for people or anything like that. These are just grossly inflated profits that can be cut and used to different purposes. So those are the main components that we are looking at. There's many more, and there's a lot more detail to this, but that's what we chose to present to you tonight, to begin to, for people to help get a handle on this. And I hope that that was helpful and not boring, and was that okay? Okay. Thank you. You're also nice. It really did pain me to do this. So now going into action mode, Nick's going to come back up here and talk to y'all.
Right. Hello again. I was actually just told that we may need to be out of here by 8:45, so
Go right into Q&A.
yeah, we're going to try to be brief, but we do want to explain some of the opportunities for action that you have, because you have to do something about this. I mean, we all have to do something about this. So there are tables in the back for you to take action. Basically, we have local, state, and national action opportunities for you. We've talked about, some of the local efforts that the Healthcare Access Task Force and the Medicare Task Force have been doing. So there's information about joining those task forces. There's information about the next meetings. There is a petition that you can sign to, say that you support increased access to healthcare in this community, in this area, and everywhere basically. For the state, a lot of the work that we're going to be doing here in the coming months in Illinois is around the single-payer legislation that Dr. Sheets was talking about. HB 311 is going to be up for consideration again later on when the people come back to Springfield for the veto session. So we're going to be continuing to support that legislation. There's a letter to Representative Flowers that you can add your name to that says that you are thanking her for for sponsoring that legislation, and she sponsored it year after year, and it's continued to get more in support. It actually is co-sponsored by Representative Jacobson here in this area. Nationally, you can support, get information about supporting the Kucinich Amendment that Claudia talked about. You can get information about how to make improvements to HR 3200 and the broader health reform, because there is plenty of improvements to be made. There's information about the HR 676 and how you can get behind that. So basically just know the fight's not over. There's still plenty that you can do, that we all can do, and they need to hear from the consumers. They need to hear from the people, because it can't just be Obama and Congress that are making these decisions. They need to hear from you to, to get the right thing done. So plenty of ways for you to get involved. And now we'll have some time for Q&A, hopefully.
Yeah. One thing also, and we will alternate between, between questions from cards and also questions from the audience. And what I would like to do is also see if Dr. Sheets and Al would be willing to ask questions. Again, remember, please, no commentary, no testimonial. We got to go quick, so straight to questions. Be brief, and then
to come stand up here?
Sure, if you don't mind standing, that would be great.
Should I just go hand these to you?
Yeah.
Or, yeah.
And if you want to direct your question to one person in particular, please do that. Okay, would somebody like to ask a question? Okay.
I have a question. I don't really understand the exchanges. I work with elderly and go through the Medicare handbook with them with the Advantage plans, and there's like hundreds that they can choose from, and it's just confusing and it's crazy. I mean, you look at it and you think it's crazy. So how would this be different? The exchange, would it be another big gigantic list of things they had to pick from that they wouldn't have a clue what they're deciding? Is that what it would be?
Yes, it would.
Well,
yeah. So that's one of the things that would have to be made user-friendly if possible at all. But those of you who do have that kind of experience, whether it's Part D or working with that, that's our fear. Yep. Okay. And then, oh no, should I? If y'all want to look at a question and see if you want to ask it. Let me take one more from the floor, and then we'll read one. The lady in the purple, or in the with the green skirt.
Yes, I am in a unique perspective where I do work with medical debt as a profession, and I have been recently diagnosed with a potential lifelong condition. Do you, as a organization, CCHCC, accept volunteers to work for your organization?
Oh, well, thank you. I know y'all think we planted her, but we did not. Yes, Yes, we do, absolutely. And actually, at the back of the room, if you will go and talk to somebody, there we'll take down your name and set up a time to meet with you. And absolutely. Thank you very much. Okay. Is there a question?
Yeah, I can address these. The benefits of a co-op, if any, I would say there aren't any. I mean, this is another situation of trying to fix things with something that can't fix it. You try to get a group of people or a group of organizations together to buy health insurance. We already know that that's going to fail, so there aren't any benefits to that. Triggering an option means if the health insurance companies don't, this is one of the ideas, if they don't manage to decrease healthcare costs within 5 years, that triggers the public option. And again, that's just it's a non-solution to anything.
Can I say something about that? One thing I want to say about that is, why is it okay to wait for 5 years and suffer and see something fail? Because when health insurance fails, people hurt. People get hurt. People die. We do have clients who have died. We do have clients who are in that number of 20,000 a year who die simply because they lack, insurance. So waiting 5 years to see if this works or not is really unacceptable.
Okay, there's a question about non-citizens. I'm going to address that. And I'll speak specifically about HR 676, which is the legislation that I support. Yes, it covers every person who lives in the country. Why? We don't distinguish among people who are citizens or who are not, because we believe that healthcare is a human right. It belongs to everyone. Additional factors, non-citizens pay taxes. Everybody who lives in this country and gets a paycheck pays taxes. If you buy food, you pay sales tax. If you pay rent, you're helping to pay property taxes. They are paying taxes. They get less benefit from those taxes than other people because there are many things they don't qualify for. Do you want to be sitting next to somebody anywhere who does not have access to health care and can't get health care if they have tuberculosis? Do you want people handling your food who cannot get health care if they have health problems? It just doesn't make any sense to exclude some people. And also, if Americans go abroad to the publicly funded systems, we get care there.
I suppose the answer to that is yes. But I don't think there's anything in the legislation regarding pharmaceutical companies, although I thought there was a provision about the government being able to negotiate with discounts for pharmaceuticals. I think that's in there for Part D. But I'm not qualified to speak on behalf of pharma. Do you want to?
No.
How is, next question was, how is Obama's proposals last evening, how do they compare with H.R. 3200 and the Senate Help Committee listed on the green sheet? Is it a stop? Is it a stopgap? Or weaker proposal than these two? I didn't hear anything in President Obama's speech last night that disagreed or that conflicted with.
Yeah, it's pretty much the same.
Okay, all right, then I'm not qualified to address that, so
No, I
so I
think
won't.
I think it's very similar.
Yeah.
Did you have another one? We should take some from the, hang on a second. We're going to take about 2 more. This lady's had her hand up. Go ahead.
For those of us on Medicare who have Advantage programs, what else is there in Champaign-Urbana area? I mean, Health Alliance, Personal Care, Humana, to help pay for the things that Medicare doesn't cover. You know, if the Advantage plans are not good, then what's our alternative?
Do you want to go for it?
What was the question?
Oh, can you restate the question?
The question was, what else besides Health Alliance's Medicare Advantage plan, Personal Care's Medicare Advantage plan, Humana's Medicare Advantage plan, what else is available what else is available as choices for people on Medicare? And of course, the other thing is the other programs that are available are the traditional Medicare supplement policies that are that are standardized, and those can be purchased. But I think that's the extent of it.
Can I say something about that? and I didn't mean to imply that the Advantage plans are bad from a direct consumer perspective. The reason that people like the Advantage plans is because of what Dr. Sheets was saying before about sort of that Medicare needs to be improved. It doesn't cover enough yet, and people take Advantage plans to try to control their out-of-pocket costs. I think the Advantage plans will be able to continue if the insurance companies are willing to do them at that reduced profit, because they're going to get their overpayments cut. But we'll see what happens. But the Advantage plans also have not delivered the benefits that they promised. One of the things that they promised was on a national level to reduce the cost of Medicare by managing care in a different way and providing more benefits, more preventive health and stuff like that. And the studies show that basically they haven't done that. But from your perspective, probably it's been nice to know what your copay is when you go to the doctor and things like that. So yeah, so it's a thorny issue, but I think it goes back to the point that Dr. Sheets made that there are changes that need to be made to Medicare, and our Medicare task force actually came up with a whole set of recommendations for that, so that people wouldn't even need Advantage plans. Okay, one more question at the back, the gentleman in the blue shirt.
I just wanted to ask, this is particularly, I guess, directed to the physicians group and Champion Healthcare Coalition. Are there any plans for any actions that would dramatize the need for, real change and who the enemy is, like for-profit health insurance, other than writing letters and lobbying? Is there any plans for any kind of direct action, which seems to be what's been necessary to make significant changes in other areas of society over the past? When is there going to be some demonstrations at health insurance companies and that kind of stuff?
Well, we have had demonstrations there have been demonstrations at healthcare companies. In Chicago, we've certainly done them, and in some other places. It's easier to do, obviously, in a big city than in a smaller area, because you have more people just to draw on, and there are people who are not going to be threatened personally if they demonstrate at the insurance company and get retaliated against in some way. Maddis Health Doctors is a group from Oregon, a group of physicians from Oregon who are traveling across the country doing various kinds of more dramatic presentations. They're going to be in Chicago on the 25th and 26th of September, and in Gary the previous weekend. So, and people are certainly, you can go to Maddis Health Doctors Chicago and RSVP for the event if you want to do that. And beyond that, there has been civil disobedience. 13 people were arrested in Senator Baucus's hearings for standing up and speaking out for single payer, and we do anticipate a growing civil disobedience movement. And people who are interested in that should be talking about it and getting educated from the people who have long experience with civil disobedience. This is a movement in the making, and it is all of us, all of you and all of us who are making it, and we don't yet know what we're going to need to do, but it needs every one of us taking part in deciding what it is that we need to do and then doing it.
Thank you very much. I'm going to wrap up, and so that people can go to the tables or ask questions. We have to be out of here by 8:45. If there's refreshments left, take some. I just want to wrap up by thanking the speakers who spoke this evening. I want to thank all the co-sponsors, and I want to thank all of you who came here and spent this time with us this evening. And the last thing that I want to say is that this is a long haul struggle, and I thank you all for staying committed, building the movement, and working for the change ultimately that we need. And it's not going to be easy or pretty along the way, but the important thing is to not go away and to not stop working on it. And that's our commitment to you, and we hope you'll be part of that as well. Thank you all very much.